So I'm going to talk, my official title is Global Prevalence of Age-Related Macular Degeneration. And I do promise I'm going to talk about that. But I would also like to raise some points that I think as a community of responsible doctors and researchers, we also need to consider. Because the way things are going, we're going to have a lot more people with AMD, and we probably won't be able to, and seriously don't want to, get down the road of injecting everyone at the end, sort of towards the end of their life. So I think we've got to think about some earlier strategies that might be able to help us to combat disease around the world. So I would like to start, and if we could dim that light a bit, because I've got a few pictures. So I would like to start with just one of the cases, and I will show you another one, because there are two major points I would like to consider right at the beginning of my talk, and we'll come back to this theme a few times. So this is one of my patients, and if you just watch the back of the eye, those of you not ophthalmologists, this is the optic nerve. This is the very back of the eye. The very center of the vision is here, and there. And these whitish yellowish blobs are what we call drusen. Drusen is, those of you who speak German, you know that, those little eggs that you used to find, and then when they cut them in half or break them in half, there was those little crystals in the middle that stood up. And and you see them in every sort of gemology shop and everywhere else. So drusen, these are these yellow deposits, and they were considered to be, or they are still considered to be, the hallmark of the disease. But we don't really understand how they form, and we don't really understand why some people can withstand the damage for a very long time. So these are external to the retinal pigment epithelium. That's a lot of them. There are other types of drusen. We'll come to that in terms of why it is so important that we understand them. So this is one of my patients who's very symptomatic, extremely long after images when he drives, barely can see in the dark, really has a lot of symptoms, but the vision is 6/6, 20/20 or 1, whichever country you work in. You can sort of use the appropriate one. You can see that the drusen are growing. They're taking up much more space. And he's just a very unhappy chap because he doesn't really enjoy his visual tasks anymore. Okay? When we measure his visual acuity in a high contrast, high luminance area, then he's doing very well. You do a mesopic visual acuity or visual acuity in a sort of a less of a good lit environment, and he can't see as much. So 5 years later, this is really a nearly complete sheet of deposits. This is all just junk, whatever it is. And then he's still very good vision. 7 years later, you practically can't see the good structures of the retina, and he's still very good vision. He's given up driving, and he moved in from the country to further into town because he simply cannot see enough to drive. Okay, and this is excellent vision. This is where sort of some of the other tests we need to consider, and the other areas of visual function we need to consider for our patients come in. So this is a complete sheet of just absolute junk that the retina cannot clear. And then 10 years later, he comes back. To the casual observer, the eye looks slightly better. A lot of the drusen disappeared. But areas of atrophy appeared, and his vision crashed in about a year and a half to 6/24. He's now the same. The other eye looked exactly the same. So he now is below the legal limit of driving as well. So he's now losing vision because areas of atrophy develop. So what we used to tell these patients, that you'll always be able to dress yourself, you will always be able to get around, you will always be able to do your daily chores. But then a couple of my other patients started talking about really, when you quiz them, they don't really come out with it. When you quiz them, they talk about sort of a night blindness, not the deep one that you see in patients with macular retinitis pigmentosa or any other peripheral dystrophies. But you sort of, this patient, his already got some atrophy, fixates right at the edge of it, and there is quite a lot of drusen. He's 6'9", whatever you want it, and his main symptom is night blindness. We did do an electrodiagnostics, which practically showed very little subnormal rod function. But when you look at it, his periphery was full of drusen as well. So we've started looking at the periphery. Ophthalmologists historically in the last 20, 30 years, we've been terrible at looking at the periphery for these patients because age-related macular degeneration has always been considered to be a macular disease. I think with new imaging modalities, which we're also going to talk about, but also with just looking at some of our patients' periphery, we're going to have to reconsider that. And we're also going to have to reconsider as to what we will say to these patients, because these patients don't always live in a well-lit environment. They live all around the world in very poorly serviced areas as well. So this is what we used to tell them, that AMD will lead to loss of ability to read and drive, but you're always going to have a reasonable surrounding vision. Not great, but reasonable. But we need to somehow reconsider that. So what does AMD do to your life? So if you look at the disability of adjusted life years for macular degeneration, which means that how much of healthy life you're losing if you have macular degeneration. And it's really a sort of a measurement of the gap between your current health status and your ideal health. You see, so the redder it is, the worse it is. And you can see that despite the AMD being the leading cause of blindness in the Western world, in the people amongst the retired age group, the actual impact of being blind from macular disease, whatever it is, in the developing world is phenomenal. Because if you can't get around, then you're going to have a huge issue with being able to get just to the well, to get water, or to be able to look after your grandchildren, which traditionally in a lot of communities was the elder's job. So if you think about it, where are you going to find a lot of information? And there is this phenomenal work that's going on with the Global Burden of Disease database. And within that, there is the Global Vision database. And it's sort of run out from Anglia Ruskin University. And if any of you want to see it, it's about 2 corners down from here. And what they're doing is that they're trying to synthesize all the studies that we know, that we have, try to work out what is the absolute impact of losing sight from different diseases. So the data, there is a wonderful paper in Lancet, and then BJO carried 7 or 10 articles, one after the other, on the different continents. So they were looking for national, subnational data. They're looking for relative risk of over 60% for losing whatever disease they were looking at. Lowest limit of visual acuity was 612. This is where they looked at. And they looked at how badly the different genders are affected. And what did they find? This is a very sobering map, I think. The whiter the area, the less information we have on knowing what is happening in that country on visual loss and blindness. So it's quite amazing that if you look at Canada, there are practically no population-based studies in Canada that would be good enough quality to feed into the database. I'm not saying that there is nothing there, but nothing that they could integrate with the database. And practically the whole of Eastern Central Europe, Russia, is all missing data. We know actually more about Africa than we know about Europe. It's a very sobering thought. It is really not very well appreciated. You know, it is much easier to get money to do studies in Africa than to do in Eastern Central Europe. And they're not just talking about the Ukraine, but you know, anywhere else. It's actually reasonably safe to be in Austria or Hungary or Poland and places like that. So there's no good reason why we shouldn't know much more about those areas. So I think the map itself is a great way of looking at it, where the lack of information is and where we don't know about what is happening. So we, as you know, we have been looking at, in ophthalmology, we have been looking at reducing the burden of the avoidable burden of blindness. And by 2020, we wanted to reduce it by about half. I don't necessarily think it's going to happen in every area. But the avoidable blindness is the cataract, uncorrected refractive error, trachoma, glaucoma, and diabetic retinopathy. So we have managed to reduce moderate and severe visual loss from 80% to 76%. And as you can see, the avoidable blindness is slowly going down. The unavoidable, which for diseases such as macular degeneration, where we have no real cure, is slowly going up. But it's just a tide turning, or is it really in absolute numbers the disease is getting less? So I tossed and turned if I was going to give you like millions of slides with percentages, or are we going to just sort of summarize it? But I think if you have a look at this slide, you can see that in the word blindness, pretty much everything is on a downward trend, slightly. It's the cataract issue that has made a huge impact. Operating on cataract in the developing world has really made an impact. AMD is the yellow line. It's actually sort of relatively steady, and it is going down in a lot of parts of the world, but it's going down in absolute percentages of people being blind. But because we are living longer, the number of people blind are more. Okay, so there is a little bit of a discrepancy in how you interpret the data. We always have to remember that we are talking about the population exposure. We do talk about Africa and Asia and the Indonesian and China and India especially coming online of living long enough and being able to get to the stage when they get age-related macular disease. But with some of the theories, some of the new therapies, the percentage of blindness caused by age-related macular disease is actually slowly decreasing. But this is moderate and severe visual loss and blindness. We have no ways of really measuring how people do how do people function in their daily life when they are trying to live with age-related macular disease. And so this is just the second slide, and I'm not going to put, this is Europe, sort of the visual age-related macular degeneration is remarkably steady, and it's the percentage of blindness. What it means that we are making a dent with some of the therapies. I don't know if we are making headways with trying to stop people converting to end-stage disease, or is it all down to us being able to treat the end-stage disease of choroidal neovascularization? But despite population growth, the percentage of people going blind didn't actually go up from age-related macular degeneration. What did go up is the moderate and severe visual loss. And I think a lot of these people are those who we treat with different anti-VEGFs. And despite that, they will develop atrophy, a lot of them. So if you look at it, every single part of the word looks exactly the same. The yellow is all the way through the age-related macular disease. So it is the second, the second from the top. And you can see that there is a slight decrease in every country of the percentage, but they're not the numbers. Okay? So we have to remember that. What is really upsetting, I think, is that we're making absolutely no headway with correcting for refractive error. Refractive error in every part of the world, including North America and in Europe, is the most common cause of visual impairment. And I think sort of giving glasses should not be so difficult that we can't manage. So if we try to sort of do it in a different way, wherever you go, Mild visual loss is going down as well. Moderate and global blindness is going down as well, but the numbers of people are increasing. The number of people we need to look after are increasing. So what happens with if you look at women and men? Women are, in every part of the world, women go blind much more than men. Women do live longer, so they do have much more of a chance to go blind as well, so you need to remember that. But also, in many areas of the world, women tend to have less care because they don't necessarily accept care, and that's the same in East London as well. So our blindness statistics is still horrible for women of certain minority groups. So what did we do? So is it just coming to, is it just the developed world? It isn't. So we did a big study in Kenya, and we are just analyzing the incident data, which will be the first incident study in Africa. But what we are finding is that you know, the AMD, early and late AMD percentages, so early when they just have the drusen and a lot of junk in the back of the eye, and this is when sort of they have end-stage disease, things are either dying away or they are being sort of difficult to, you have difficulty to see. And they on the images, you see a lot of this disease. If you just sit at the slit lamp, there is a serious undergrading. So the previous studies and RABs and things like that, the rapid assessment of avoidable blindness, probably does underestimate the percentage of people with AMD and those who have early disease as well. Again, you know, this is not something that you need to. This is not something that, in terms of Africa, will be a small number. Just remember that most African countries have no access to intravitreal injections. So if you see that's given in any given year in this area, a small area in the Nakuru, the Rift Valley in Kenya, this is how many people will be going blind. So if we think about it. This is what we used to see. And we used to see these patients without treatment, and even if you go back in the literature, even within the European countries, we couldn't agree what it was. Germans called it the continuous, the English called it the age-related fibrovascular macular scar, secondary to age-related macular degeneration. So how are we going to cope with the incidence and the prevalence estimates of the disease when we don't really even have a very good terminology of how to call the disease and which part of the disease is important? So we used to look at fluorescein angiography and painstakingly decide if the percentage of the very white was slightly bigger than the percentage of less white. That, fortunately, isn't as important anymore for the OCT, for the anti-VEGF injections. But in parts of the world, there is really no way of doing fluorescein angiography. Even parts of Europe has no fluorescein angiography available to them. So we have to really remember that we're relying a lot on the color photographs. We're also relying a lot now on the OCT, or optical coherence tomography images. And one of the issues with having new technology is that every time we look around, there is a new classification. So when we try to establish the incidence of the disease for something like age-related macular disease, people like this one, who had no deposits or very little deposit under, this is the retinal pigment epithelium, there's very little underneath, but you see these little blimps here, you know, is this AMD? And we used to call this age-related macular degeneration because it's under this line, everything, and this is the choroid. But now, now, the wrong way. Now we've got a lot more information from the OCT scans. So people started adding the OCT information to the classification, which means that suddenly our prevalence and incidence rate shot up because we see a lot more. And we have to remember that, you know, if we do want to sell this to the governments, that it's really important to look after the people. Having too little problems that no one else can see except if you have a high-resolution optical coherence tomography imaging is not going to go down well because they are unlikely to be able to treat that such early disease. Once you have complete loss of the outer retina, vision drops, and you will have visual loss. So where do we go from here? So we used to be able to image this area, and this was the area based on which we have made all the decision on. But now we've got ultraviolet field imaging. So this is one of our patients. This is a massive area of atrophy, and you've got drusen outside of the macula as well. And now, when we can image them, you can see that there is a lot of drusen outside. And when you do autofluorescence images, which shows which areas are dead, a lot of dead areas outside as well. This is what we used to call the age-related macular degeneration end stage of wet type. But if you have a look at the periphery isn't normal. So is this a macular disease, or is this a retinal disease? How are we going to classify it? How are we going to look at the impact of the disease? Exactly the same here. So some of the issues that we can do is the biobanks are able to store a lot of data. UK Biobank has 500,000 people, 112,000 of which we have imaged and have genome-wide and saliva and urine and everything else, and we also graded them. So that will be able to give us some information. But we also, again, look at other areas, such as the Alzheimer field. So when we look at the Alzheimer patient, we see that they have many more drusen in the periphery, enormous small hard drusen in the periphery. And they actually progress very fast. Within 2 years, all the red dots appear. That does not happen in non-Alzheimer patients. It's not easy to image them, so there is a lot of learning to do. But what you want to do is we want to learn, and we want to be able to connect the two diseases. In a sense, it might not be truly connected, but what we can learn from the Alzheimer field would be great. And if we can help the Alzheimer field to reduce the amount of testing they need to do and have the eye as a biomarker, that would be a fantastic opportunity. So just to finish off, I think there's a very sobering thought of the African nature again. So you need to think about that. But this is, when I go to Botswana, this is what they usually have. That's usually goat and that's shogun, so you can actually sort of have that. This is the following day's meal. That's, again, goats and something else. And then about once a week, I find a place where there is a little bit of green and yellow and orange colored pigment. And if we think about that you know, the current prevalence isn't lower, and there is the diet and the lifestyle changes are coming in. I think we're going to have to look at the global prevalence and incidence of blindness very carefully, again, to be able to help people around the world. Thank you for your attention.
Thank you, Tunde.
Oh, sorry.
Room for questions, please.
Dr. Mulcahy yesterday drew attention to the fact that in Okinawa, people live a long time, as you know, but they don't get Alzheimer's. Are there any countries like that in the world where they have a special diet? Because obviously the diet in Okinawa is quite different from what we eat. It's mainly Japanese plus fruit, Japanese diet plus fruit. Have you any information that might show any light, say, that an increased intake of lutein might be preventative?
For Alzheimer. I think Imre is talking about Alzheimer next, so I'm going to...
About AMD.
Oh, AMD, okay. It's a difficult one because the Icelandic and the Greenland diet is actually quite similar with lots of fish and very little vegetables to the Japanese diet. And they have the highest percentage of age-related macular disease, the dry type, anywhere in the world. They don't really have the wet type. So it's very difficult. And also in Asia and Japan, they have a slightly different type of AMD called polypoidal. So they have little polyps, a little bit like varicose veins in the leg, in the very back of the eye, in the choroidal layer. And we don't really understand why they get that kind, which is devastating when it bleeds, although it might not be such a huge number, but it's a devastating outcome, and it doesn't really respond to treatment very well. Some will, but most will not. So there are a couple of big studies coming out of Singapore that are looking into the genetics of polypoidal disease, which might be able to give us some better understanding why they have that.
But they don't, would you say that's AMD?
We call it AMD at the moment. It's the spectrum of the disease, but I agree, it again comes down to how we classify the disease.
John?
Yeah, thank you for your presentation. I wanted to ask about the impact of anti-VEGF therapy in the long run. Robert Kuckling brought to my attention, following his presence at a conference in Germany, some work presented by Frank Holz that suggested that while directly, obviously, anti-VEGF therapy is successful, it cleans up the retina, there's a visual improvement which is beneficial, but if you allow life continue and age, that in the background the disease continues to develop. And I just wonder at what stage how do we calculate or quantify the cost effectiveness of this drug, which is very expensive, versus other potential preventative treatments? How do we deal with that?
It's a very good question. There have been several major trials, Brand in Holland, and they're all finding that 2-3 years down the line, a lot of patients are going into atrophy. And we also see that both in AMD treated with anti-VEGF and in diabetes. So it is going to, I don't think anyone expected the magnitude of the atrophy. I'm not sure why, but I think we were just sort of quite cynically hoping that we can prolong good vision for long enough in an elderly population that they will have a stroke or a heart attack or some other disease that will take them away before they go blind from the atrophy caused by us injecting very many times. So, so I think we were hoping that prolongation of good vision will be enough to see them through the remaining part of their life. But you have to remember that people with AMD tend to be fairly healthy. It's not like the diabetic population where they have lots of other diseases with their diabetic macular edema. By the time they get there, they tend to be quite sick anyway. So I think none of the, as far as I'm aware, none of the governments and policy groups are looking into the late complications of anti-VEGF therapy. It's at the moment just emerging. We are just regrading the IVAN trial, and I know that they're regrading the CAT trial patients, and we've just got funded to get them back, the IVAN patients back 5 years down the line, to see how many of them developed frank atrophy. But even at the 2-year point, there were quite a number of atrophied patients. So we're going to have to put that into the equation, because eventually, if they only gain 2 to 5 years for that amount of money, then the cost effectiveness of the drug will be seriously affected. As opposed to being very effective, you will have to think about how effective it is in real life.
Thank you.
But this does not negate the fact that it does give some patients very good quality of vision in between.
Time for a final question.
Thank you very much. That was really interesting. I wonder if anybody's looked at mild cognitive impairment to look at that distribution of drusen around the eye, because I guess that's the bit that starts to be critical. Is it coming before there's any symptoms, or is it something that's only evidence after?
Do you want to take that, or shall I? Because you're going to talk about that, is that right? No, you're not. Okay. So there are a couple of studies ongoing at the moment that are looking at especially the wide field imaging and the mild cognitive impairment. The cohort we had and we had followed and that is in sort of a 2-3 year follow-up, they were quite severe. And we didn't know what to expect. So I wouldn't design the study again that way, but hindsight is wonderful. And every study would be perfect if we had the hindsight at the beginning. But the MRC and the Wellcome are working on a feasibility study, and we are analyzing the eyes of deep and frequent phenotyping. And so those patients have relatively mild disease, and I agree we should be trying to get them at the mild cognitive stage, because if you could intervene then, or if you could have a reliable biomarker then it would be great for some of the Alzheimer's studies as well, because doing PET scans and things like that every 2-3 months is not feasible, not just because of the radiation, but also because of the cost.
Thank you very much.
Okay, let's thank the speaker again.